Welcome to Week 6. Last week we covered cohort studies, the logical design that follows exposure to disease. This week, we flipped the perspective with case control studies. Case control studies start with disease status and look backward to exposure. They're counterintuitive at first but tremendously efficient, especially for rare diseases. While a cohort study might need 100,000 participants followed for 20 years to accumulate enough cancer cases, a case control study can enroll 500 cases and 500 controls and be completed in a year. Many landmark discoveries came from case control studies. The link between smoking and lung cancer was first established through case control studies by Dahl and Hill in the 1950s. Thalidomide's teratogenic effects were identified through case control analysis. Let me walk you through case control design step by step. You start by identifying cases, people who have developed the disease of interest. These might come from a hospital, a registry, or a defined population. Case definition must be clear and consistently applied. Then you select controls, people who don't have the disease but come from the same population that gave rise to the cases. Control selection is critical and often the most challenging aspect of case control design. For both cases and controls, you ascertain exposure history. Did they smoke? What medications did they take? What did they eat? This usually requires interviews, questionnaires, or record review. You compare the proportion exposed among cases versus controls. If 80% of lung cancer cases smoked but only 40% of controls smoked, there's an association. The measure of association is the odds ratio. Because we sample based on disease status, we can't calculate true risks. But when disease is rare in the population, the odds ratio approximates the relative risk. Case and control selection are the critical methodological decisions. For cases, you need a clear, standardized definition. Incident cases, newly diagnosed, are preferred over prevalent cases because prevalent cases overrepresent survivors. Hospital-based cases are convenient but may not represent all cases in the population. Controls must represent the same population that produced the cases. If a person in the source population developed the disease, they would have become a case. Controls tell us the expected exposure prevalence in that population. Hospital controls are convenient but may be biased if their conditions share risk factors with the disease under study. Population controls better represent the source population but are harder to recruit. Matching controls to cases on potential confounders like age and sex improves efficiency. But matched variables can't be studied as exposures, and matched analysis is required. Using multiple controls per case increases statistical power, but returns diminish beyond about 4-to-1 ratios. Case control studies have distinctive strengths and limitations. The major strength is efficiency for rare diseases. A disease affecting 1 in 10,000 people would require enormous cohorts. Case control studies can enroll available cases directly. They're faster and cheaper than cohort studies. Multiple exposures can be assessed once cases and controls are enrolled. One study can test many hypotheses about risk factors. Recall bias is a major limitation. Cases may remember exposures differently than controls, especially if they've been thinking about what caused their illness. A cancer patient might scrutinize their past diet more carefully than a healthy control. You cannot calculate true disease incidence or risk from case control data because you sampled on disease status. The odds ratio is your measure of association. Control selection is challenging. If controls don't represent the source population, your odds ratio is biased. Many case control studies have been criticized for inappropriate control selection. The thalidomide tragedy illustrates case control studies in action. In the late 1950s and early 1960s, physicians noticed a sudden increase in babies born with phocomelia, severely shortened limbs. This rare condition had become dramatically more common. Case control studies compared mothers of affected infants to mothers of normal infants. Researchers asked about medications, infections, and other exposures during pregnancy. The studies revealed that mothers of cases were far more likely to have taken thalidomide for morning sickness. The association was strong and specific. Thalidomide used during a critical window of pregnancy, days 20 to 36 after conception, correlated with limb defects. This discovery led to thalidomide's withdrawal and strengthened drug regulation worldwide, including Canada's current pre-market approval requirements. The case control design was essential here. With a rare outcome, cohort studies would have been impractical. The need for rapid answers demanded an efficient design. Case control methodology delivered. Let's summarize case control studies. The design logic is backward compared to cohort studies: start with disease status, look back at exposures. This seems counterintuitive but enables tremendous efficiency. Case control studies are ideal for rare diseases where cohort studies would be impractical. They're also valuable in outbreak investigations when rapid answers are needed. The odds ratio is your measure of association. When disease is rare, typically less than 10% in the population, it approximates the relative risk. This rare disease assumption is usually satisfied. Control selection determines validity. Controls must represent the population that gave rise to the cases. Poor control selection can bias results in either direction. Recall bias is the other major threat. Cases may recall exposures differently than controls, especially for diseases where patients search for explanations. For healthcare managers, case control evidence is common in the literature and useful for rapid assessment. Understand its strengths and limitations when applying findings to practice. Next week, we reach the top of the evidence hierarchy: randomized controlled trials. See you next week.